Good morning, everyone. Welcome to the Capital District Special Education Task Force. Our monthly training for today is mental health, a continued discussion. We're going to talk about risk factors, challenges, intervention, and a whole lot of great stuff with some great people presenting today here. I want to mention May is Mental Health Month, and one of our founding members on the executive council for the task force about the video you just watched passed away this year. Her name was Ruth Fennelly. And I just wanted to mention her name. Mental health was like her mission in life and helping people who had that. And we miss her. And I hope she's watching over us today. And I hope that she approves of what we're doing to raise awareness in today's training. Helen, you had mentioned it's a little technical thing I overheard. You said you're going to put out a training. I think you meant to put out a survey. Is it a survey about the when we're done today? Make sure you fill out the survey for this training to let us know what you think and if you liked it or not and ways we could improve. So we ask everyone to please fill those out because we use them every year to try to improve. We listen to everything you say. So please make sure you fill those out when we're done today. Okay, I'm going to do a brief introduction about myself. I'm going to ask our panel to introduce themselves, and then we're going to get started. I will just say my name's Steve Oil. I work at Northern Rivers Family Services for over 15 years now. I've been in human services since long ago when I had hair, over 30 years now. And I've loved everything I've done, but I've never been more passionate about the work that I've been doing here for 15 years as a family peer support person, helping parents of youth that have mental health issues. And I've become an advocate through that as well, educational and systems advocate. And for all that I loved about human services, this is the most important work. And it was my child that led me to this direction when he was diagnosed with autism when he was a toddler. So I always say it's interesting where your kids bring you. And I'm grateful for that. At the time, tragic diagnosis and very upsetting diagnosis. And yet it's led me to help other people in a way I never thought I'd be able to do. So that's me. I'll be sharing a little bit today, but mostly we're going to hear from our other panelists. And I'm going to start, if it's okay, with Marie McCabe. If you could tell us a few things about yourself.
Hi, I'm Marie McCabe. I'm a neuropsychologist and I work with kids. I have a private practice in Saratoga Springs, and then I also work in the neurology department at Albany Med. I moved to the Capital District a little bit more than 10 years ago, which was kind of daunting. I've actually never lived any place this long except for where I grew up. So it's lovely and also a little surprising. But it's been a great learning and kind of collaboration experience working on this. And so I'm eager to talk with you guys and hear what everyone has to say.
Great. Thank you, Marie. I think I'd like to go to Stacia next. If you could introduce yourself for us.
Hi, I'm Stacia Downey. I'm a psychiatric nurse practitioner at Ellis Child and Adolescent Treatment Services. I'm in the outpatient clinic. And I've been a nurse for about 36 years, which I kind of realized just recently, and a psychiatric NP for 4 years. That was all at Ellis. I've worked in the schools as a special education consultant. In my former life, I was in the United States Army, and I'm also a mom of twin sons, adult sons with autism. So it's been a long road and a lot of learning along the way. But I'm glad that Steve asked me to do this.
Great. Thank you, Stacia. Alex, I want to ask you to introduce yourself, and then I think I'm just going to let you roll into the next slide with Helen and get started, okay?
That's great, Steve. My name is Alexandra Lucien. I am the Assistant Director at the Split Northeast for the Day Education Program. I have worked for Northern Rivers / Northeast for just over 12 years. I've been at the school for about almost 9 years now. And prior to that, I actually worked in our residential program, the residential program for Northeast Parent and Child Society. I met Steve probably about, I don't know, it's got to be 5 or 6 years ago now, when my daughter was diagnosed with autism, which originally we thought was autism, and then we later learned was a rare neurodevelopmental disorder called Rett syndrome. So, but I met Steve in sort of asking questions about where to go with this diagnosis and exploring school programs that would be appropriate for my daughter. So I have done a lot of work with Steve as both a parent and an advocate and a provider in a lot of different settings. And I'm very happy to be here today to present for you guys. So I am going to start with the first slide that we have. So I wanted to start the presentation kind of giving you guys some terminology. It's probably terms you've heard before and or know what they mean, but I kind of wanted to start here because I think that this is an important place when talking about mental health to recognize and understand. So the first term I wanted to talk about are called risk factors. So what we know is that in some children, there are higher risk for developing mental illnesses, including substance use disorders. And these risk factors that contribute to this are based in a lot of different areas, specifically genes, biology, environment, culture, lifestyle. Specifically, we look at genetics, stressors in that young person's life, trauma experiences. Maybe does that individual struggling with identity issues, family dysfunction, other illnesses, poverty, or involvement in the juvenile justice system, or substance abuse. So if I go a little bit deeper with each of those, when we're looking at genetics, specifically, we're looking at like a family history of mental illness. Children who have had a parent or an immediate family member that has struggled with mental health issues is at a higher risk of developing one too. There are mental health issues that this is more prevalent amongst, specifically if you look at schizophrenia or bipolar disorder. There is a stronger family linkage to those, but it can be, with other disorders, depression, ADHD, and others as well. But it's important to say, although most people with mental illnesses do not necessarily have relatives that have had a mental health issue at some point in their life. When we look at stress, chronic stress, what we know is that chronic stress can lead to anxiety and depression, amongst other mental health issues, and it's a major risk factor for substance abuse. It is probably one of the largest contributors that we have seen to increases in mental health diagnoses and substance abuse diagnoses, particularly post-COVID, is that a lot of people were struggling with managing stressors associated with that. Another important stressor that I think we have to call out specifically in light of recent events in our state specifically is racism. Children experience racism directly and indirectly, and that is impactful on them, even if indirectly, by witnessing the effects of racism. This is particularly true amongst children in the BIPOC population, so Black, Indigenous, people of color population, and that they're experiencing these things. And oftentimes they don't understand, if you're talking about younger children, they may not understand why they're experiencing these things. And it can cause them stress and anxiety that can contribute to longer term, mental health issues. Kind of hand in hand with this has been traumas, like we talk about traumas, such as physical, emotional, sexual abuse, neglect, witnessing abuse, witnessing violence, being a victim of violence. All of these types of things are contributors to mental health issues. I like to talk about ACEs, and I don't know how many may be familiar with LaSalle's school, the LaSalle School, which is a Capital Region program that does a symposium each year on ACEs. So ACEs, by definition, are adverse childhood experiences. And these are things that happen in childhood that have a dramatic effect. What we know biologically is that experiencing ACEs actually changes the way a brain develops in an adolescent. It changes the way they respond to stimuli around them, and it changes the way that they experience the world around them. It was very interesting when I did my graduate studies that they actually did MRIs and scans of brains that actually showed structural differences in young people who had experienced significant traumas in their childhood. So I think that that is probably one of the most important factors when we're looking at youth and children to consider when looking at the possibility of a mental health issue developing. Next, we kind of focus on identity issues. So we know a lot of young people experiencing issues with how they identify sex or gender wise, and or how they identify with regards to their sexuality. There are a lot of stressors associated with coming out and identifying that to family members or friends and whatnot, and that can be a contributor to, again, stress that can lead to mental health issues. Family dysfunction, so a chaotic family of origin or a chaotic family system or an unstable family system can be a leading cause of mental health issues. Other illnesses, so physical illnesses or disabilities can also, be a precursor to a mental health issue. Poverty, the experiences associated with poverty can come with a lot of trauma or a lot of considerable stress and insecurity that can be, again, a contributor to mental health development. Juvenile justice systems, involvement with the juvenile justice system or the child welfare system. I will talk about later how those things can be impactful, but again, are contributors. And then substance abuse, whether that's their own use with substances, which again, we know in adolescence and childhood, use of substances can impact brain development, but also exposure to substance use, whether that be after birth and parental exposure or in utero exposure to substance use can again change brain chemistry, change biology, development of brains, and impact mental health development down the road. So, and I think next slide, protective factors. So the counter to kind of these risk factors are then protective factors. We all experience various levels of some of those risk factors in life. How we manage our experiences with those risk factors is by developing a strong protective factors in our lives. So, one of the single most important protective factor can be family stability or community stability or a support system. When children, particularly children, experience some of these things, it's important for them to learn to work through those things, and having strong family members or a community or a support system that guides them through that can really be a significant protective factor, and having a normative experience with those stressors as opposed to an experience that morphs into sort of a mental health disorder or an anxiety or depression that is unmanageable. But often these protective factors are attributes and skills and resources that are around a person. So, I have on this kind of graphic here, different types of protective factors and different ways that providers can be protective factors for students and adolescents. Friends, having a good and important friend group can be helpful in that. LGBTQ adolescents who have a loving and supportive home that are embracing and helping them with that identity and those struggles associated with recognizing those things is significantly important in reducing long-term mental health issues related to that process and identity. Despite these protective factors, though, some adolescents will still develop mental health issues. And I think it's important that when we see that morphing, that we're able to recognize and intervene as soon as possible. That is, I'm all set.
Okay, I'm gonna jump in and talk a little bit about typical cognitive development. And I debated about this, but I'm gonna start with some of these kind of stage models that may bring you back to graduate school or undergrad, but don't worry, we won't get too stuck in the weeds with them. So this is Piaget's stages of cognitive development. And I think we'll kind of weave some of this into our talk about mental health and emotional development going forward too. And interestingly, actually was kind of interesting in thinking about this now at this point. he is basically describing the evolution of the way that children think. And that was actually sort of revolutionary at the time in which he developed this idea and model. We might sort of laugh at the idea or sort of chuckle at the idea that younger children don't just think more slowly than older children, or that kids aren't sort of just small adults sort of packaged in a small body. But those were kind of new ideas at this point. And I think like intellectually, we know that kids think differently than adults do, or that young kids think differently than adolescents do. But actually like really kind of getting in it is useful to appreciate even on a daily basis in working with your own kids and your students and those who come into contact. So this picture is like a really kind of simple way of describing his theory, which is that, you know, a young baby, of course, is going to learn about the world by seeing and touching. So the kid there is holding a glass of water, and that's sort of how they interact with this world in a very kind of concrete, tangible way. And then the younger elementary school age kid, the preschool age kid can kind of like imagine water and could maybe talk about a concept without it actually being present. You know, with a baby or a 2-year-old, you can't usually talk about something unless it's sort of physically there. That's where we're at. It's really kind of concrete. And then this middle group, or that third age of kid, can talk about like some reasoning, can do a little bit of logic and reasoning with respect to new topics and ideas. And I think interestingly, like, you know, attention sort of develops in parallel with this, and therefore this like later elementary age kid can stay with a topic a little bit longer and start to do a little bit of abstract thinking about it. And then the older kind of adolescent looking kid here can think about kind of the nuance and the maybe some morality or some philosophical topics and ideas related to what begins as a really concrete topic and idea. And so you can kind of see like this development of more abstract and conceptual thinking skills that happen over the course of development in youth at different rates, but certainly does happen. And actually, I think when we think about this in terms of learning about or understanding emotional development, you know, if we kind of like, I think often it can be sort of frustrating working with these young kids, like these kind of 2 to 7-year-old age kids who are really struggling to regulate emotion. And as we think back to like this sort of slide, which I think is a reasonable framework for understanding kids' development, you know, at that age, like having kids work on recognizing and labeling feelings, that's a reasonable place to be at. Those are reasonable skills to work on given this child likely cognitive development and functioning. And then when the kids get a little older in that kind of 9-10 range, they can more consistently be a little more thoughtful about like what other people might be feeling. They can kind of imagine that. They might be able to imagine how they feel in a situation, even if they're not in that situation right then. So I think there's really some relevance of this. I think it likely, you can think of how it is relevant. And then I was going to talk a little bit about Erikson stages too. If you could go to the next slide, Helen. Thanks. And so he described emotional and social development over the course of a lifetime, actually, not just in youth. And I'm just going to talk really about the two, the school age one and the adolescent one. But the idea is that these stages build upon one another, and that each has like sort of a central conflict that is to be resolved or not, and that results in you know, continued development or perhaps some concerns about emotional and social development. And so the school age conflict is about learning, and about learning from encouragement and feedback from those people around us that that our efforts, that our work lead to success, and that leads to a feeling of competence and then confidence. You can, as I was preparing this, it kind of makes you think about like imagine sort of the impact of a learning disability at this stage when you don't have the same automatic positive feedback loops that tell you that you're doing a great job, that your effort is productive and leading to success. And then likewise, kind of hearkening back to something Alex just mentioned about like the importance of having a cheerleader, a trusted adult, and just that persistent finding about how protective having even a single strong, trusted relationship with an adult in childhood can be. And that I think really maps pretty nicely onto this this model. And then in adolescence, again, I just sort of smiled and like looking back at this and thinking about identity and role confusion. I don't think we have to do too much imagining to understand that is sort of what adolescence is about, and trying on different selves and different versions of ourselves, and that being encouraged to do that exploration and appreciating that exploration as normal and part of development is a really essential piece. And so we can think about all different kinds of exploration that people do, like like all of the changes in friend groups and relationships that happen around that time. And experimentation with things like drugs and alcohol, but also with things like gender and pronouns and dress and style that are really baked into what adolescence and determining your identity is about, and the importance of having someone affirm your sense of identity and you as a person, sort of regardless of the self that you're trying on. Okay, so these stages, just about all of these stage models, they're convenient and they are models. They are not precise, but they are useful, and they do offer some guidance. But I think we all know, like, development isn't this neat and organized. We don't move from one stage to the next and then never return to an earlier stage. Even in typically developing kids, there's back and forth, and that's anticipated and expected. And I think, sometimes when I'm thinking about this, I imagine development as this sort of series of bursts and then kind of plateauing and then another burst, and it's not a neat linear picture. And also I just sometimes imagine like there's so much variability in stage. These are kind of averages, but I will sort of think about like, this is really a really concrete example, but kids, when they lose their teeth, and sort of the variability in appearance of first and second grade kids. And, you can see how variable that is when kids lose teeth. It's all kind of around this time. But I think that's a reasonable way of thinking about cognitive and emotional development too, that there's a breadth of time in which these things happen. I'm going to talk a bit about brain development here and kind of how it maps on to cognitive and emotional stages. You can go ahead, Helen. This next picture is an old image from a 1975 paper, actually, by Carell. And it shows, you can see how neuronal and dendritic growth. So these are pictures of neurons in the brain from newborn, and then kind of a pause at 2 years, and then up to adulthood. And so you can see how the picture looks different as we get older. And so in these kind of infancy stages of 1 month and 9 months, you can see the proliferation or the growth of neurons and connections between neurons. And actually, if you kind of think back to all of that sensory motor exploration that like Piaget described and that we all know and see, we can kind of see like how this happens in the world, that all of that exploration is leading to production of neurons and new connections and growth. And then by adulthood, the picture actually looks really different if you kind of compare those 2 years and 2-year-old picture to adulthood. There's a process here that it's going on that's called pruning, which is really just and it's a natural and normal process where neurons and connections between neurons that aren't used in a consistent way deteriorate. And so our strongest circuits, the neuronal connections that are repeatedly used and accessed, get stronger. And so our brains develop networks of connections that serve our cognitive and emotional functioning. And then those circuits, are sort of self-reinforcing, that they get used and reinforced and built through repeated use and also through experience and our environmental exposure. So you can go on to the next slide, which kind of builds on this. So you can see this is a picture of it's an MRI picture, an fMRI picture of language processes. In this case, it's comprehension, language comprehension. But actually the task isn't that important. What I want to illustrate is how broadly the brain is used in younger kids, those kids who are not yet 5, to complete this task, understanding language, and then how the brain activation, the amount of brain territory that is used as kids get older decreases. And that's because we become more efficient. And so those brain, it's that process of pruning and building brain networks. And that's actually what we anticipate. And this is a particular task about language comprehension, but in fact, this same thing happens broadly with all cognitive function. And so we become more efficient and specialized in terms of what we can do. And I also think, as I was thinking about this, it's reasonable to think about, like, if you think about what young children observe, what they notice, they're amazing noticers. They notice things that we don't notice. And I think that really maps onto this understanding of brain development and neuronal development. There's all kinds of regions that are firing in kids that aren't for us when we're out in the world and doing things. My kid just yesterday picked up this like small container of glitter from like a pile of rocks that I'm walking right past, and she's noticing all of these things, and it fits. That's what her brain is meant to do. And so the last thing I want to say about this is just that we come into the world, Alex had alluded to this too, with a blueprint, which is our genetics and our brain architecture, or the way that our brain develops and the way the circuits in our brains develop are shaped by experience. We're built by our experience. And I think that kind of makes me think back to Erikson's stages and the importance of affirmation and encouragement and having those protective factors that promote resilience in our day-to-day life, to promote cognitive development, but also emotional health and well-being. Stacia,
Just have to unmute myself. Hi. I just want to go over some of the things I see with the patients presenting and families in my office. Right now, teens and adolescents tend to be very poor communicators under normal circumstances. So it's up to us as parents and guardians to engage them and ask questions. Any change in behavior that strikes you as odd or different might be a sign that something's wrong. So we're all very, very busy. There's a lot of anxiety during the COVID pandemic, and with the schedule changes are making so many families have such difficult times. They don't know when their children are going to school, when they're going to be out, dealing with getting virtual learning up and running. There's just so many things we've had to deal with lately, the children and the families. But we get so busy with all of our demands that sometimes we're not as attentive to what's right in front of us with our children. And often it's difficult to notice the subtle changes in mood and behavior with our children. So basically pay attention to them. Stop what you're doing, take a look, be aware of their expressions, their reactions to things around them, and engage them. A really good thing is to engage them in daily activities with you, because sometimes we get so busy and it's easier to do things for ourselves quickly by ourselves. But when you engage your children and you bring them in, and if they're teenagers, they're going to give you a hard time. But just this one thing, and engage them, bring them with you, because then that increases your time to be able to observe them and maybe even get some information out of them about how things are going. Because you want to be aware of their social contacts and who may influence them. So basically, warning signs of mental health challenges: if you see mood changes, smiling less, more anxiety, irritability, maybe answering you quickly with more sharper mood, their reactions not really matching if you're asking them a simple question and they react, more angry, more irritable, if they're more withdrawn. These are just subtle changes that you'll notice, which are normal in many circumstances. But when they're coupled with other things, you kind of can put the whole picture together and see that something's wrong. If you see them self-isolating, spending more time on social media and less time with family and friends, like I said, a lot of that's normal for teenagers, but sometimes it can be excessive, especially, and we don't notice because we're so busy. A big thing is a loss of interest in previously enjoyed activities. Changes in sleep pattern. Be aware of when they're going to bed, encourage an earlier bedtime, or if they have excessive sleep. Most of the kids I see have difficulty falling asleep, waking up in the middle of the night, because that seems to be when the things that bother them are worse. And another thing that happens, unfortunately, very often is self-injurious behavior. And you might not even notice if they're wearing long sleeves in the summer, just even sometimes subtle scratching or hurting themselves. That's how they're learning, even from others, from their peers, how to express their anxiety and their depression. Taking risks, unsafe behavior, and then a big one, if they're very, very depressed, which hopefully you'll see many warning signs before this, but if they seem to be unable to discuss future plans and just kind of appear to lack hope for future, when you're talking about things in the future and they're really not interested, that's a big sign. Okay, so it's basically just watching your child, try to engage them, and being as involved as you can with all of the demands that you have right now. Next slide. And this is this you, Marie?
Me, I got it.
Oh, Alex, okay.
So I want to talk a little bit here about how mental health can impact children and adolescents. What we know about, we were all kids. We all had to come from somewhere. Growing up is hard, or can be hard, particularly when you kind of hit those adolescence, teenage years. But even as a younger child, there's a lot of stress to do well in school, to be liked by your peers, to get along with your family. As you get older, making decisions, whether it be, about friends and relationships and things like that, but also about college or what you're going to do after school, or even just keep going to school in general. A lot of these pressures can't be avoided, and many of them are normal that, for kids to experience. But also being a parent or a caregiver or even a provider for that child can be hard, right? You're watching this child experience all of these different stressors and wanting to figure out how to help, and you've got a child who is going through physical changes, emotional changes, hormonal changes, sexual changes, social changes, all of these types of things. And every child is different. So, your blueprint for how to help one child is going to be completely different. So it can be hard to be that parent or that caregiver, trying to figure it all out. But so for youth where we see mental health having the most impact is typically within their family, within their school setting or environment, and then particularly for children who have involvement with the juvenile justice system or the child welfare systems, as I mentioned earlier. So I'm going to start with family and talk about a little bit about how mental health challenges may be impactful to families. So frequently the behavior that we see from children or adolescents with mental health issues poses a challenge to the parents in multiple ways, right? So the parents and the siblings. First, it's that this may be a new experience for that family and they don't know what's happening. They don't understand what's happening to their child. So that may be the initial challenge of just trying to figure out what they're looking at. Stacia gave a lot of good things to be aware of and to be watching for. But those may be things that parents are starting to see and experience, and they don't know what to do about it. They don't know how to intervene, how to be helpful. So because of this, the parents can feel strained, which can put a strain on the relationship with that child. But that child may also start to experience some behaviors that may put a strain on that family, behaviors at school that result in the parents being called or a caregiver being called to the school. And those are stressors. Those can be stressors for parents. Nobody wants to get that phone call that, their kid had, a major incident in school or a fight with somebody or a fight with a teacher or anything like that. Nobody wants to get that phone call. And so that can make parents feel that they are not doing something that they're supposed to be doing, or and leave them with feeling, again, like I said, hopeless or not knowing how to be helpful to that child. In some situations, the conflict that arises out of that can be blamed on the child, which just kind of then perpetuates, any stressor that child is feeling that is contributing to any mental health issue that they're having. So it's important, when you're kind of trying to work with that child around what's going on. So as a provider, that you look at the family as a whole and maybe work with the family as a whole, because oftentimes it's not an issue unique to the child, but an issue for the whole family. In school, how this may manifest in school, or how mental health issues may manifest in school, is that a child may have a difficult time succeeding. And it's not because they don't want to succeed, but it's because they can't succeed for whatever reason in that moment in time. They may have behaviors or thoughts or emotions that are interfering with their ability to be successful in the classroom. For any of us going into work every day with maybe a stressor on our mind or things like that, impact our ability to be the best that we can be at our jobs. For a child that may not have the emotional vocabulary to express what they're feeling or what's going on for them, going into a school environment and having all of this swirling in their minds and not knowing who to talk to or how to talk about it, just can be very overwhelming. And just it can lend itself to just sort of being like math and science are not a priority in that moment. Particularly when you're looking at elementary or middle school age children, you may see a child that's unhappy at school, that comes to school and just kind of sees down or depressed often. That child may be absent frequently from school, or you may see behaviors that are resulting in suspension or even expulsion from, a school system, a school setting. Their learning is negatively impacted, could be negatively impacted because of poor concentration, distractibility, inability to retain information, poor peer relationships, or aggressive behavior. So any of those things may result in that child being withdrawn or failing to engage, which will obviously impact their ability to be successful in school. As you progress towards high school, you'll see kids that maybe are dropping out of school because they haven't been successful or have struggled to maintain or manage within the school environment for could be for a long time. All of the things that we talked about that, in elementary or middle school that lend themselves to a child maybe not having the same level of success in school or not achieving in a way, it carries over once you kind of reach that high school stage. And now you may have a student that is delayed in terms of their academic development or understanding of things. You have a kid that kind of reaches ninth grade and they really don't have the foundational skills that they needed. And so now they're in ninth grade and they're kind of stuck because at ninth grade, you have credit earning that you have to do in order to move through high school. And a kid, you may have had a kid that kind of was promoted, through elementary school and middle school, just kind of based on the way that the school system works. And now they're kind of stuck because they didn't really learn what they needed to learn earlier on. This lends itself, you see an overwhelming number of kids that kind of get stuck in that 9th grade year, and ultimately end up dropping out because they feel hopeless or defeated, or that there's no possibility of them having success. So that can be, a significant challenge in high school. You may also see, as Marie mentioned kind of earlier, is that we're entering that stage where experimenting or trying different things is normal to a certain degree, but it can also end up being overutilized, particularly when you're looking at substance use. There's other at-risk behaviors, like Stacia mentioned, high-risk sexual behaviors. Those they may start to engage about in. Just trying to think. All of these things can lead to, that teen sort of feeling marginalized or shunned by peers or society and things like that, which again, would just kind of perpetuate any mental health challenges that they're experiencing in that time. An interesting statistic that I read is that 1/3 of students with a serious mental health challenge do not move on to post-secondary education in any way. And that's a staggering number, 1/3. So that's 1 in 3 students in any classroom, if they're experiencing a mental health issue, may not move on to post-secondary education. The statistics associated with this are just compounded if you look at a child that is involved in the juvenile justice system or the child welfare systems. Oftentimes within the child welfare system, you have a youth that has probably already experienced some sort of trauma or had some sort of negative adverse experience in their life. So now we've got already that risk factor in this equation, and then you couple it with instability at home, an unstable home environment, or unstable support system, and all of those things. And it just kind of ends up perpetuating on itself or building upon itself. Oftentimes you see kids that are involved in the juvenile justice system there's a strong correlation between involvement in juvenile justice system and a mental health diagnosis or a mental health misdiagnosis. And again, it's not because that child doesn't want to engage in pro-social behaviors in the community, but they're struggling and they don't know how to be helped. They haven't had the resources in place to help them be successful and avoid sort of negative outcomes. So again, I think we talk a lot about the value of support systems and having a trusted adult that a child can go to and say, like, something just doesn't feel right, or something's not sitting right, or I'm having this experience and I really need to figure out what to do with it. Because all of these things can really help steer kids away from, sort of these factors that are going to compound any mental health issues that they may be experiencing. We see a disproportional a number of young people who are members of racially or ethnically marginalized groups falling into these sort of juvenile justice or child welfare systems. And if we compound all of those experiences that they've maybe had in childhood with, racial experiences or biases, stressors, all other things with these other aspects, you're really just kind of looking at a perfect storm for negative outcomes without intervention, without appropriate levels of intervention happening. And I know, I think that there's a part of me that, as I prepared this presentation and looked at all of these different factors, is that it really can sound overwhelming or overwhelming to think about what the path is for a child that is experiencing some of these things or having these struggles or presenting with these struggles. But I think it's important to also remember that for many, many, many youth, mental health episodes mental health challenges are episodic. They're not necessarily chronic or long-term. It may be the result of, stressors and temporary stressors in their life. And with the appropriate levels of support and intervention, that child can move beyond that struggle that they were having in that moment in time. With developmental changes sort of come natural transitions, and and again, those are normal things. But again, that child may need support in navigating some of those normal transitions in life. And without that support, the outcomes can be different. I think the next slide would be good, Helen. All right, I'm going to pass this one on.
That's me, Stacia. Okay, I definitely want to reinforce what Alex is saying, because what the reinforcing the need for supports for the kids, even just sometimes we don't realize that just providing a little bit of attention or a kind word, and the positive supports, catching them being good, giving them praise. It just goes such a long way with these kids. It makes them feel good, and it gives them inspiration to do more and to try to do a better job, or to, if someone takes an interest in them and something they're doing and gives positive supports, very often they feel good about it and they continue learning, and they might go in that direction. We went over a lot of the basic impacts of mental health challenges, but this is more, this slide discusses more of what you're going to see in school, and what I hear from teachers, their reports, that inattentive during class, off task, not turning in homework because they leave school and they just don't have the interest, and sometimes with the feelings of depression and anxiety, the things, like we said, the things that they were interested in before, they're not interested in right now. They'll miss class, they avoid or withdraw from extracurricular activities, and a lot of times parents complain a lot that they're holed up in their room. So, and engaging them is not easy, because especially the teenagers, they will argue and they'll have a reason. They have so many reasons that they come up with to avoid being with the family if they really are not interested in they're feeling depressed or anxious. And sometimes parents were busy, exhausted, and you give up, but you have to keep trying. Like a case study that we all wanted to discuss some case studies, and one that I had encountered was, we call her AK. She excelled on the school track team. She received excellent grades, always interacted with friends and teachers, and was generally happy. Then she was isolated at home. And this is the story of many children isolated at home during COVID quarantine. And she was an only child. And in her case, both of her parents worked outside of the home. They were first responders and had to be gone for many long hours. So feelings of depression and anxiety increased without the in-person social interaction. Her grades dropped, and her interests in things that used to make her happy had decreased. And then I find the families in my office coming in after the 2-year major quarantine period. And I think everybody thought that we would just flip a switch and we're back to normal and everybody's in school and everything's going to be okay and go right back to the way we were. But some of the children have a really hard time adjusting. So for AK, it was very difficult for her to adjust. The sudden exposure to the social interactions and new demands was overwhelming. And there was a suicide attempt, and that required hospitalization. And that hospitalization provided the supports that she and her parents didn't even realize that they needed. So basically the takeaway is increase your communication with your children and increase awareness of behavior changes to prevent tragedy. And most of these situations, thank God, do have a happy ending once the supports are accessed. Okay, and next slide.
So Stacia talked about one sort of presentation, a turning inward, disengaged presentation. But what we can also see with students struggling with mental health challenges is kind of the opposite, right? That they turn outward or become more disruptive. So that could look like, particularly in school, if we're focusing, on acting out, or in homes, that the child starts to act out more, that they present as angry often, or they're getting into arguments and fights more frequently. So another example or case study that reflects this And I should back up and say, I talked about that I work for Northern Rivers at the school at Northeast. Just to give you a little, for anybody who may not know about the school at Northeast, is we are a special education program located in Schenectady, New York, for students who have special education involvement when have an IEP. Usually a classification of emotional disturbance, OHI, learning disability are typically our focus areas. Often these students have presented with social and emotional challenges in a public school setting that have rendered the public school unable to support the student in the way that they need to be supported. So at that point, the student is referred to my school for additional support. Our classrooms have smaller class sizes. We have an increased staff to student ratio, and all of our students are assigned to a clinician that works with them kind of directly in the program, supporting them on managing the factors that have contributed to them not being successful in school. You know, I like to call our clinicians kind of social workers on steroids. That's the way I look at it. So, so this, this scenario very well could be any of the students that we serve. It's something that we see very often in my setting. We have a student who lives in a two-parent household. Growing up, it was a fun and loving relationship with the parents. Over time, as that student aged, she started to notice her parents having more conflict, and particularly more verbal conflict, and with arguments that would extend, well into the night, and disrupt, her sleeping patterns. On occasion, those conflicts would become physical, or there would be property destruction in the home as a result of the conflicts that the parents were having. So each day that student would go to school, or the student would come to school, and would often be sleeping in their classrooms, and just completely not engaged in the classwork that was happening in class, or they would be disruptive and unfocused and unattending to what was going on. The students started to bully peers in the building, and in the classroom, and would be getting into fights a bit more frequently, was getting into fights more frequently. Grades started to fall due to, lack of engagement, sometimes absent from school, and just refusal to do work, or being suspended as a result of the fights and things like that would ultimately be suspended. When teachers would address it, particularly like the sleeping in the class or the behaviors that the student was having, she would get angry with that teacher, and then get into, start lashing out at the teacher and get into a verbal conflict with the teacher. Because of sort of, the increase in the suspensions and problems in school, the parents were then called into the school to discuss the issues the student was having. And the parents would interact with the, school staff, and, we're sorry for, the behaviors that she's having, but then it would go home and it would just lead to more conflict, conflict with the parents and conflict with this young lady, because, they kind of were blaming her for the issues she was having in school. As a school employee and working in a school, and unfortunately, as I said, seeing this presentation very often, it's important to look for red flags in these things. Oftentimes students are not coming into school and sleeping just because, you know what I mean? And I think that we've talked a lot about the importance of having that strong support system, or a strong, trusting adult that individual can talk to. I think it's important to recognize, things that are happening, or specifically dynamic changes in behavior that may be occurring. And taking the time to maybe engage that student one-on-one, build a rapport with that student, so that maybe you can talk about, what's going on, what's happening. I'm concerned. I really want to figure out how to be helpful to you, so that student may have an outlet to talk about some of these behaviors, because a lot of what, this child was experiencing at home, she didn't have an outlet to talk about, her concerns related to it. And so as a result, she was holding all of that stuff tight to her chest, and then lashing out on people. So being able to recognize that mental health issues, or mental health challenges, or depression doesn't always look like being down and crying and depressed and sitting in a corner, it may look very much the opposite in that you're lashing out. And it's not necessarily always behavioral. It can be related to, some sort of struggle or some sort of trigger that is going on in that person's personal life or in their home environment. So I think next slide, yeah.
If I could quickly interrupt, I just want to let our team know it's a few minutes after 11. I think we're doing pretty well. I'm counting the slides as we go, but I think we're doing well, but I just want to let you know that. Thank you.
Thank you.
I'm going to actually kind of go quickly over this one. This is just another sort of presentation, a way that mental health challenges can come up. So kids due to worry and anxiety, perhaps about being in public, may end up not being able to get to school because they're so anxious and concerned about how they're perceived by peers, by staff, by teachers. Concern about unmasking. Actually, I'm sure people heard about this quite a bit among adolescents, which, perhaps like surprised you when you first heard about it, but in practice, actually, it makes a lot of sense when we think about kind of typical adolescent development and concern about appearance and presentation, that has made returning to school unmasked really challenging for many kids, and trouble with anxiety and feeling nervous can look like attention problems. Actually, very often does look like attention problems. These kids may have trouble focusing during a test or in class. They may have trouble sleeping at night, which further impacts attention. So I think the number of questions and referrals that I see right now that are about attention, but really seem to be truly about anxiety, has really increased since the pandemic, and trying to kind of sort out the timeline of all these things and how attention difficulties manifest, sometimes looking to be primary, but actually are a consequence of anxiety. So these are just some ways that mental health can impact day-to-day presentation. All right, I just want to make sure we get to like the end of our presentation with all of our kind of thoughts about what to do. So I'll let the next person jump in there.
It's not me, is it?
Sorry, I'm just talking away and unmuted here. Or muted here. So we spent a lot of time talking about how mental health, and a lot of the scenarios and examples that we gave you were about mental health challenge and presentations with typically developing students. But I think it's also important that we think about atypical development. And when we talk about atypical development, we are talking about, like maybe a co-occurring ADHD or anxiety diagnosis, autism, learning disability, or an intellectual disability. What we all should know is that we're not necessarily going to see the impact be different with an atypical developing individual. There's still going to be an impact on the family. There's still going to be an impact on school and community life. So I think it's important that, we recognize that all of the things that I kind of talked about earlier and all of the impacts that they have is still going to be true with an atypical developing student. Where things may become more challenging is that you are now looking at mental health in addition to maybe this co-occurring disorder. And that can lend itself to oftentimes a lot of complications, I would say, more so in the realm of treatment and diagnosing. So when we look at like treatment and diagnostic health, I'm sorry, I just wanted to when we look at treatment and diagnostic health, one of the things that may happen is that diagnosis may be missed or misdiagnosed. There could be barriers to testing and evaluating for a mental health diagnosis, either due to maybe a practitioner not being as familiar with that co-occurring disorder, or an interference from that co-occurring disorder in properly diagnosing that mental health disorder. This is often called what we call like there can be sort of a masking, I guess would be the best way to phrase it. So there can be diagnostic overshadowing, which is a term that refers to when symptoms of co-occurring disorder may present like a mental health disorder. Oftentimes, I think one of the most prevalent voices that I have seen this is reactive attachment disorder. So oftentimes when you've had a kid that has had, so reactive attachment disorder is a diagnosis when a kid ends sort of their early childhood stages, where recognizing healthy attachments with a caregiver is very important to how they view the world or how they interact with the world. When there's some sort of disruption in that early attachment, it can lead to this, a diagnosis called reactive attachment disorder. And there can be a lot of ways that reactive attachment disorder manifests that may make people think it's something else. Reactive attachment disorder often is coupled with like sensory issues or social issues or interactions and things like that. And it can often present as autism. And people may think that it's an autism related disorder when you're actually looking at something else. So that would be kind of an example of maybe diagnostic overshadowing. You also have medication masking. So a student, an individual, a child may be on medication to manage another co-occurring disorder, whether it be, you know, a physical disorder or something of that nature, that could be causing physical issues or neurological issues that present as a mental health issue, when really we're looking at maybe a medication issue. So that can be a challenge that comes up with it in an atypical developing individual. You also have communication deficits. So this one for me is personally resonates. My daughter is nonverbal. So for me, and for any other, you know, parent or provider interacting with somebody who's nonverbal, it can be a challenge to know what they're experiencing, what's going on for them, and knowing how to be helpful to them because they can't communicate in a conventional manner. Oftentimes you have to, you know, you hope that that individual has some sort of alternative means of communication, whether it be, you know, an ASL or a speech generating device or some sort of augmented communication device. Atypical presentation of psychiatric disorder. So some diagnoses may present slightly different in individuals with atypical development or an intellectual disability of some nature. And then you also have episodic presentations. So it's maybe symptoms that are not currently present, but can, you know, come intermittently present themselves. And that could be related to the co-occurring disorder and interfere with proper diagnosis of a mental health issue. So kind of based on all of these different things, it doesn't mean that there aren't appropriate interventions that could be utilized for individuals with atypical development. It just means that you may have to modify how you're providing those interventions. So when we think about maybe therapy or something of that nature, you may need to change the level of the language you're using. You may need to maybe use a more colloquial language than, you know, than some providers may be used to, or you may need to alter the words that you're using just so that they are maybe more developmentally appropriate to where that individual is. The frequency of your sessions may need to be different. Typically, so like in my program, typically our clinicians provide 40-minute sessions to our students. Not all students can tolerate sitting and interacting for 40 minutes with somebody. They may need to break that up into 2 20-minute sessions, or maybe today it's a 15-minute and tomorrow it can be a longer session or something of that nature. So that's something to take into consideration. Maybe sitting in a session, you know, particularly if you're looking at a kid with an executive functioning disorder or a processing disorder, sitting down and having a session in an office for 40 minutes, it could be absolutely unbearable for that child. And so being able to walk maybe with that child or engage them in sort of physical activity that might distract them or help them maintain their focus may be important to consider. Duration of therapy, right? So it may not be that you're looking at this long intensive therapy program, because that may not be what's the most effective intervention for that individual based on their presentation. Using a structured or direct approach or concrete examples kind of thing may be important for that child based on their learning style or what, you know, how their presentation impacts that. So you may need to come with very concrete, maybe visual presentation presentation things to help with your therapy session, so that child can relate to what you're saying or see what you're saying, because they may need to see an actual example as opposed to just hearing somebody talk about what's going on. Overall, it's just important that the therapist be flexible and supportive in recognizing what's going on, or that provider be flexible and recognizing what that student's struggles are and be able to accommodate where they need to be. Be respectful. I think presumed competence is always an important factor for me. And I know it's been something important as a parent. You never want to assume that or box a child in based on what you think about their capabilities. You want to presume that they're competent and let them guide you as to whether that's beyond their capabilities or whether you need to dial it back or whether you need to progress further. So I think that for me is important when you're thinking about intervening with a student that may have atypical development. I think we're ready for the next slide. I think I threw this slide in here because I think the first portion of this can be a lot, right? We gave a lot of information, and sometimes some of it may sound overwhelming and might be like, oh my goodness, what do I do with all of this? I think it's just important to always remember, we can get through this. And I think, the next part of this presentation is kind of gonna give you some thoughts and ideas about how to get through this. So I kind of just wanted to say, take a moment and say, we got this, we got you, we're gonna help you get through this. So, all right.
Okay, thanks, Alex. Stacia, well, what can we do? You heard from Alex and Marie, many things we can do as parents and caregivers and providers. But of course, people come into my office and looking for possible, sometimes definitely, medication management. So medications. I think sometimes people don't realize medications we treat specific symptoms. So you have to look at the child and you have to tease out what's the primary thing bothering this child right now. Specific symptoms would be anxiety, depression, hyperactivity, distractibility, inattention, sleep problems. And each one of those symptoms is treated by a different category of medications. Medications are specific categories to treat symptoms, and very often medications are used off-label, especially with children. So ideally, we like to start with medications that are FDA approved and on label to treat these specific symptoms. And medications, if I could record it, there's no magic pill. You want to use medications in conjunction with counseling in most cases. Medications and counseling both do create physical changes in the brain structure and brain and responses, and they work together. And the counseling just takes a little bit longer. But what I've been in my office for quite a while, so I have a lot of children now who just have some basic medication management when they need it, but they started out with medications and counseling together, which is ideal. And I know it's very difficult to access providers at this time, but ideally that usually gives you the best results. And then some of them require medications that could be into adulthood, and you can fade the counseling as they do better emotionally and behaviorally. And sometimes we fade the medications, and the counseling is just maybe once a month, just to touch base. It's always good to touch base with your provider when things come up. Medications work to reduce the symptoms that the child is feeling so that the counseling can be more effective. You're not going to be able to counsel a child who's extremely hyperactive, inattentive, distractible, angry, irritable, and then sleep is so important. If these children can have a regular bedtime and a good sleep schedule, so many of the the medications that I prescribe really aren't needed, or are needed in much lower doses. If you can get really good sleep and have a schedule every night. And I'm seeing with a lot of kids, it's not happening. Okay, so with medications, you want to start low and go slow. They take time to work, most of them. There are some categories like the stimulants for ADHD that work pretty quickly. You can see it in anywhere from 2 days to a week, whether these medications are going to help or cause side effects. And also, I can't stress enough that every child responds differently. I can give the same medication to 2 or 3 different children and have totally different responses. So basically, you try low doses, and if you get okay results, you can try increasing, but ideally you want to go slowly with increases and observe for changes in symptoms and behavior. Monitor these effects, report them to your provider, and always ask questions. As a nurse for so many years, I used to love being in the hospital with patients, and the doctor would come in and speak and tell them all of this wonderful information, and the doctor would leave, and the patient would look at me and say, okay, so what did he say? So make sure you ask questions, because that's what they're there for, your providers, to answer your questions and help you understand and help you to know what symptoms to watch out for. And the dosing, it's better to increase medication as needed based on the symptoms than to prescribe too much initially, because sometimes you can have a medication that parents will come in and say, oh, that didn't work. But either it wasn't trialed for a long enough period of time, because some of the medications take quite a long time, a few weeks, to hit all those brain receptors and cause an effect. Or it's prescribed in a dose that may be the dose that's recommended, but your child is more sensitive to medication. So maybe your child only needs half of that initial dose, and they might have a very successful response with that low initial dose. And if it was prescribed higher, the child would have side effects, and you would call it a failure of the medication, when in reality that medication might be good if it was just at a lower dose. So all of this you can discuss with your provider, and unfortunately it takes a lot of patience for the meds to work. And it's really nice to have a counselor on board, because the counselor, so many times the counselors that work with me will come to my office or will call me and tell me things that the child and the family had forgotten, or the counselors generally see the patients longer or more frequently than I see them. So they're able to assess for many of the responses and changes, and they're able to, get a hold of me, and then I can make changes based on what I hear from the counselors also. So please just try to be in contact with your provider and consider counseling. Okay, next slide. And this is basically similar to what we've been saying. Engage in conversation with your child, carve out one-on-one time. Very often when you're alone with your child and you have a specific one-on-one time carved out and there's very little distractions, they will open up to you. So many of us we're all so busy and trying to do so many things, and it's great spending time with your child. But unless the child feels relaxed and you don't have too many distractions, sometimes they don't feel comfortable or get to that point where they'll open up to you. And you can get a lot of good information, even just a ride to the grocery store, an extended ride in the car, just the two of you. Your child might be able to open up a little better. A lot of them have poor diets, especially the teenagers. I constantly hear, I don't eat breakfast. No, I can't eat that. Oh, I don't like this. So just add a multivitamin, speak with your primary care provider, but a multivitamin that contains some vitamin D, especially in the fall, 3, 4, 5 times a week might be helpful if they don't have the best diet. Always monitor for substance use, because that will, substance use, especially the cannabis, a lot of the kids are using cannabis now, and the parents, and there's many different forms, so you might not be aware that your child is using cannabis, but it does, too much use causes an increase in anxiety. It can have mood changes, behavior changes, and it might be due to substance use instead of something else. So have that open dialogue and monitor. And like I said before, encourage the adequate sleep. Sleep is so important, and it makes a huge difference. It reduces anxiety, and it makes them more calm, reduces hyperactivity. And you can do that by reducing activity before bedtime. And I always tell them, I get the eye rolls, but shut off the phone an hour before bed. And then all the kids say, well, we can just turn off the blue light on the phone. But even just the constant attention and the constant stimulation of the phone, phones, tablets, computers, if they could somehow reduce that activity before bedtime, they might fall asleep a little better. And an important thing is to temper our reactions in order to encourage open dialogue. So many of the children, they might try speaking to you as a parent, and our immediate reaction is like, oh my God, how could you, why didn't you tell me? How could you gotta go against everything that makes sense to you in that moment. Calm down, take a breath, and sort of smile and listen. And if you don't react, you'll get a whole lot more out of your child. It's very difficult being a parent, and but I deal with the parents and the families every day, and we just kind of all try to keep encouraging each other and supporting each other. Okay, next slide.
Okay, so we wanted to talk a little bit about kind of where we go from here, what can we do? And so this slide is really just meant to sort of hold a place to describe the fact that, as we all are extremely well aware, the past 2 years have really broadly and quite significantly impacted mental health, in particular in youth, and perhaps more so in girls, but also mental health concerns and problems and crises were on the rise before COVID. And so this really exacerbated an already increasing problem. And I wanted to just highlight that this is a population level concern. Someone else, I think Alex had talked about this before too, that like mental health concerns and even crises can wax and wane. They are not necessarily lifelong. And there are things we can do that are sort of preventative strategies that are not only preventative, but are actually treatment too. And they're really maybe simple, but not easy, actually, really not easy. And importantly, some of the most important things that we can do broadly with resources that I think we can all access in some way or another. And so if you can go to the next slide, we wanted to spend some time talking about that, about kind of what we can do to protect ourselves, protect our kids, protect our community and our schools. And that's where we're going to kind of jump into now in talking about some of those things. I think Steve might be up next to highlight that.
Hey, are you sure? Okay, I think I'm ready. Well, let's look at this slide for a moment. I want to start with physical activity. When let me say, when I was in group homes, when I started working in group homes in this field some 30 years ago, what I was trained in and our common sense told us, after school, do whatever you could to get these kids outside and playing. Have some fun, and also just have some exercise. It'll help sleep. I think things are much different now in our society. We didn't have cell phones 30 years ago. We didn't have the screens and all that. But I think the principle remains the same. And if you can have an hour a day of physical activity for your youth, that would be fantastic. I also know when my son, who's an adult now, but when he was in 4th grade, his teacher was a runner. And not only that, she just believed in at that age, especially helping the brain to function and not just sitting in the chair all day. So 3 days a week, I think it was, after lunch or 1 o'clock or something, she took her class out and they would walk or run, I don't know, 20 minutes, something like that. And, I'm sure there's teachers out there saying that would be nice if I had the time. I just would challenge you to think just like the parents, like if you can fit it in, if you could fit 5 minutes into a period or 10, even at the high school level, it could make a huge difference in the day for that youth. And I think it will build on itself. So I want to quickly go over emotional support. At the moment, I'm going to get to more of that after in some of the other slides I'm going to have, but I think we've had a lot of good info about how important emotional support is today through our presentation, our speakers. So the great thing about emotional support is you don't have to know what to say, really. You just have to be there to listen. That's how I view it. So you have to just be able to be connected to a kid, ask them. And as a talker, I have learned, like, ask someone a question and then I shut up. Like, let it be, just be quiet for a minute. Let that silence sit. And you'll be surprised how often people will come back and give you some kind of a response. Social activities, I think, falls right in with physical in terms of, it's easy, I think, when they're toddlers, you bring them to the playground when you have time and you let them learn how to play with others and be around others. As they get older, it gets more complicated, but there's so many wonderful things. On social media, I saw recently there's a lot of dances happening in the area recently, not just proms, but middle school dances. And I think that's a very big organized thing. But if we can promote more social activities, it's certainly going to help. We'll keep talking about adequate sleep. I'm going to do more of that after as well. Proper nutrition, talk with your doctor about vitamins for your youth, or mention it to families if you're in the schools or a provider. I think that I don't underestimate, and I think a lot of us do underestimate how much a supplement can help. So I think that's important. Obviously, I think eating healthy is important too, but I think, whoever's treating your medically your youth, that's an important thing, and it's already come up today. I think the thing with skill development, I would just want to mention I think we're always thinking of, we have to expose our kids to a lot of stuff. And I think that's true, but I think we have to let them lead the way. I think our job as adults is to expose them and to encourage them to try, but we have to listen to what they want to do. I have neighbors who have kids who, they've done a lot of sports and all that. And sometimes the parents want them to be into music because they relate to that better. But really, what the kid likes is Taekwondo. So listen to that, I also think it's easy for parents to sometimes listen too readily to kids. In other words, they, after one meeting or one session or one activity, they're like, I don't like that. So I'm a big fan of saying, you know what? Let's do it for a month. Let's do 4 or 5 times, or let's get through this year and, this season, these 2 months. And then if you still don't like it, we can move on to something else. Especially when the kids are younger in elementary school, because I think they're still trying to figure that stuff out. As the kids get older, they really start developing their own desires and wants, and they kind of know what they're good at or what feels good or what feels right. So, but I think the thing I want to reiterate about skill development is, just like what I mentioned in my introduction, I've always been in human services and I've always liked what I've done, and I've done pretty well at it. But it's this job that I'd never thought I would do that I'm the best at and I love the most and I'm the most passionate. So I think with skilled, and so I don't want to go back to doing the other stuff I used to do, because I don't think I would be as good at that as I am at this. And I really have a passion about this. So I think it's important not to underestimate the skill development at any age when a youth is really into it and knows they're good at it or they like it and it brings them happiness, how powerful that is in terms of fighting either chronic mental health or situational mental health. Okay, by the way, I just want to say on the next couple of slides, I think I have the next couple. Please, panel, just jump in and cut me off or add if you'd like. Helen, ready for the next slide? Is this one me, everybody? Yeah, I think it is, right? Okay, thanks. So in terms of a lot of this we've talked about, connection. Sometimes I think we forget as providers. I think parents want to connect and they're always thinking about that. But sometimes I think we're busy enough in our jobs, especially in teaching, that we kind of forget that connections can make a huge difference. And I think part of that, to be very honest, I think comes from all the regulatory stuff that's come down the pike in the last decade or so with education and telling people how they have to teach and kind of taking creativity away from teachers, how it used to be. And I think that's a shame, but I think it's the reality of what we're in. So I just want to remind adults, providers, and teachers, connection with a kid is so important. I remember one person I used to work with as a care, she was a care manager, and she could not connect with this 10, 11-year-old. And he was having, I forget his mental health diagnoses. So she would go to see him after school, and he would go under his bed and hide there. And she would sit in the room in a chair. And she would tell me later on, she's like, I'm not going to get down on the floor. And I thought to myself, well, that's exactly what you should do. You should absolutely get on the floor, not even talk to him, but just lay on the floor across the room, not right next to the bed, and just let him know that you're there. I think things like that we kind of forget. So connection, and I can't say that she tried it because she did not, but that would have been my thing. I would have tried that. Let them know that you're going to meet them at their level. And there's something comforting about that. All right, I covered exercise, healthy foods. I feel like we really need a nutritionist to talk about that. But I guess because I don't believe in having power struggles about food, but I do believe in like having healthy food accessible. So the old thing about having fruits around accessible, and maybe requiring maybe eating an apple or some kind of fruit at least once every couple of days, twice a week, something like that, or encouraging it or whatnot. Okay. And I think I've kind of covered exercise and how it really helps the body. And as a layperson, I can say I have learned how it really helps your brain. So it's not just about get your body tired so you can sleep. It's really about helping your brain feel better, really feel better. And also, how many times do we know of students, whether we're parents or providers or teachers, where they need a walk break, they need 3 minutes out of the classroom, and how much for some kids that's enough. Sometimes 3 minutes of walking can get them back for a good hour in the classroom. Sometimes they need more, and we have to look at that, and we can. But let me talk about sleep and reducing time on devices for intervention. So this is kind of geared a little bit towards family right now. I think that one of the things I notice with devices is it's very addictive. That's how they're designed. Laptops, forget about desktop computers, they're kind of old school, certainly in homes. Laptops are passe when it comes to, and people use their cell phone for everything. And just about everybody has cell phones. And they're really designed for quick response. If you look at all the things that you do on your phone, it's, you get information instantly, or you want it instantly, and other, the economics of them, the shopping and whatnot, it's all designed to happen like this. It really feeds into this addictive style of the more you do it, the more you do it. How many times have you looked down? I hope that you do this, all the adults out there. You look down and you realize, you look at your phone or you look at the time, you're like, my God, I sat down at 7 o'clock, it's 10:30, 3.5 hours on my phone. How'd that even happen? So I think that's an important thing when it comes to kids. So I think we've all said it. I think Stacia was talking about like not using the phone for an hour before bed. And I agree. And at least, I think also, like, again, I don't believe in power struggles, but I believe in setting limits with youth. And I think, boy, if you can get that, if you can work it out where they don't have the phone while they're sleeping, if they try to, like, sometimes youth will say, I need the alarm clock. And I'll be like, I'll buy you an alarm clock. We'll get you an alarm clock. Because I think what happens, again, I'm not an expert at sleep at all, but I know you go through light periods of sleep and and whatnot. So kids that are having anxiety and depression and overstimulation, they're not going to be sleeping very well in the first place. So what happens if that phone's right in bed with them or on their table? They wake up, they go to the phone. They don't even think about it. And I dare to say a lot of us do that as well. The only time I bring my phone into the bedroom is if I need to get up a different time than my wife. Other than that, I leave it out in the other room because I don't want that to happen. So if you can limit that or not have it allowed in their room at all, I think you're going to get a much better win on sleep. Maybe not the first night, but I bet by the end of the first week, they'll be sleeping better because they won't be going to their phone immediately. Okay. Okay. In the interest of time, unless anyone wants to add anything, I'll move to the next slide. Okay. All right. So ideas. Okay. What can we do together? Well, again, I think Stacia was talking about this a little bit. Including 1 to 2 fun activities. You know something? I learned as an adult, I am not a good game player because I'm very competitive. People don't think that about me because I'm very easygoing and all that. But it took me into my 40s to realize I'm a bad loser. Well, I kind of knew that. And I'm a bad winner. I am not a good winner. Like I kind of do that trash talk stuff. I always think that it's fun. And then people get their feelings hurt. And I'm always surprised. So I stopped playing games for about 10, 15 years. I just wouldn't participate anymore. But I played recently on my vacation with family in a different state, played some card games and really had a good time. I realized that I've kind of grown. So I think, and I forgot that it could be fun and I don't have to be a jerk either way, whatever happens. So I think being self-aware can help us with our kids. So finding something to do. And if your kids don't, if they're adolescents, they might not be cooperative on this. So you pick stuff that you like to do, maybe something that's easy. Uno is a great game. It's easy to play. Anybody can learn it the moment you sit down. So I think card games, sometimes drawing. One time years ago, my wife went out and bought a coloring book and crayons because it was such a stressful week. And she just colored at night for about 5 days. And it really helped her to relax and it was fun. And that's a great activity to do with kids, coloring or drawing. I like coloring because it doesn't involve a lot of cleanup. It's not like painting or whatnot, or expertise. You can just find things to draw. But I think the key thing is to find things to do together. I remember when my son was growing up, I forget where I read it at the time or my wife read it, but we read a statistic that said, whatever the percentage, a much higher percentage of kids that live in a family that have dinner together greatly decreases the chances that they're going to get into substance abuse. Now, I don't even remember how that study was or the logic, but I didn't need to be sold on it. And my wife and I come from families where that's what we did. So we always, to this day, he's back home again with the COVID shutdown, and we still have dinner together. It's not every night anymore, but because we're all busy, but several times a week, we're sitting at the table together having conversation while we eat. So mealtime is a very natural time to do that. But I think you have to go with your schedule. If you're a parent that's working, or sometimes breakfast is better, sometimes it's not. So find something. And if you can't do every night, try to find as many as possible. Definitely do it on the weekends, or whenever you're not working and you're all home at the same time. Predictability. I think that's kind of funny for families because a lot of times our family lives are so unpredictable. But I think we have to strive for predictability. We really do. I think all over. I think adults, kids, and our work lives, and our school lives, and our home lives, we thrive on routines of some sort. So that doesn't happen naturally or easily unless you create a weekly schedule. So at least start with that. And then if you have to go off schedule, at least you have something you're working towards. Okay, again, I'm watching the time and I think we should move on. Unless people have something to add, please jump in, but let's move to the next one. Okay. Cook together, turn the music up. You all keeping up with that? So while you're cooking, put on some fun music that you like or that your youth likes. And maybe, especially for the adolescents, play some stuff that you both like, take turns, because maybe you're not going to like the music that they like. So let play some stuff that they like, dance to it, or move around, have some fun, and play some stuff that you like as well. Bedtime, and stick to it for a week. So it's easier when they're younger, but don't give up on it when they're older. I think Schenectady City schools are starting school later than they used to a couple of years ago. I'm not sure about that. But for years now, there's been talk of, for teenagers, it is not natural, it's not in their natural rhythms biologically to be up so early and start working at school so early. So there's been talk and some action towards starting school instead of at 7:30 at like 9 o'clock. I think one of the points there is they need their sleep as well. And they need their sleep even if they get to bed at 9 or 9:30. I think we don't have to lecture them. We just have to provide that example of why it's important to go to bed and get some sleep. So go to bed earlier. Maybe yourself. I'm the kind of guy, like my uncles used to do when we had family parties, whatnot, but I'm the kind of guy that likes to be a night owl, and I'm always falling asleep in the living room. If my son, he never saw that when he was younger because he went to bed because we made him go to bed. But if you're doing that now and your kids are still up, it's not a great example. So think about that for yourself. Like, maybe I should get to bed, or at least get them to bed before I fall asleep out there. Taking walks, taking a midday walk even for 10 minutes. So I think that's an important thing. We're not always together with our kids, but I think that's an important thing. For the adults, connecting with a neighbor, reaching out to an old friend or a coworker. We tend to reach out to people that are going to validate us, or people that we feel safe with. So I think you can go with your instincts on who to reach out to. Good Lord, don't come away from today and reach out to your neighbor if you don't like them, or if you don't know them well. All right. Like, don't do that, but just go with your instinct, and we'll go from there. I think the simple little things that we can start will be helpful. I have another thought, but I want to go to the next slide. And I think it'll be on the next slide. All right. I think I covered this. Okay. I'm going to come back to support for adults and parents, but for a minute, I'll hit these quick because we covered the phone a lot here, but put your own phone down, put it away. So if you don't want your child to have their phone out during dinner, don't take your phone out. And if you respond to that buzzing in your pocket instinctively or addictively, and you can't not look at it, then go put it away. Go lock it up in the closet in your bedroom, and then have your meal together. And then you can expect your youth to do it. And they will do it more likely because they see you're doing it. Maybe schedule some breaks where you're using the phone or accessing the phone, or just having fun on the phone. Sometimes, again, I'm not a big fan of, I don't want you getting power struggles, but sometimes, often kids do not, even young teenagers don't know what's really good for them. So turn off the internet at a certain hour, turn off your Wi-Fi. And if you have phone plans that have data, deals, you can talk to your phone provider and limit those data deals. I don't know how that works, but you should contact whoever your provider is. It's normal parenting to set limits. So like saying, well, you got to do your homework first, then we'll have fun activities, and then you can use your phone, so you don't have to make it the whole 5 hours they're home after school, but you should definitely definitely push that a little bit. Okay.
Steve, I add real
Yeah.
quick. I think it's important, the earlier you can start to sort of set those limits around appropriate use, the better off you're going to be. The kids will, I would say it's always you'll have the big behaviors before they kind of settle back in. So it's like, if you can start that earlier and kind of get that out of the way, then they'll sort of normalize and know that that's the expectation, and we'll have less of, give you less of a challenge as they get older. Steve talking about turning off the internet or turning off the data plan or things like that is a strategy that we often have to provide to our parents, because my students tend to be older, 14, 15, 16. And, the number one thing I hear from parents is like, how do I take their phone away from them? If I go to take their phone away, if they get violent or might get aggressive with me or get loud or whatever the case may be. And there's so much of that at that point that like it's hard to normalize things when you have a kid that's that older, and you do have to go to sort of more, you set the limit in terms of like limiting, preventing access. But if you can have, sort of those 10-year-olds or 12-year-olds that as you're introducing these electronics into their lives, that you are establishing clear limits with them around them, you will be so much better off in the long run.
Excellent, Alex. I agree. And even younger, for us, for our son, the first time he got a video game, like a PlayStation or whatever it was, I think he was 8 years old. And that was our conscious decision, because we knew he would not be learning if we'd be fighting that battle with him, with his autism. And we didn't expose him to it until then. And so I think for providers out there that are working with families, like that's good information, not just what Alex said, but even younger, like set limits early on. I don't want to give up on the older kids, which is, I think Stacia had said earlier, parenting is hard. It is hard. And you might sit there and go, I need my downtime. I want to use my phone when I want to use my phone. It's not that you don't deserve that, but what message are you sending your kid if you don't change your own behavior? Like you need to have credibility with your kids. And then it's much more likely that they're not going to give you as hard a time. So it is hard, but it's important. Okay. And the last down on this one, just anticipate boredom. So many activities you can find to do, like have them like they do in some of these of our schools, put them in a box, have them accessible, have them nearby, saying, seems like a good time to, hey, we haven't talked today at all about reading. Like, how about reading a book? How about reading a book that you enjoy, not one you have to read for school? Things like that, read together. But having a list of activities or a basket or a box of where they can go, I think is very helpful when you're saying, well, you have to do some of this before you have your phone. Okay, next slide. All right, let me quickly, what time is it? I don't think I'm on answer frame. I think that's going to be Marie. But first, I just want to mention about, for parents, with the other slides, I just want to talk about, support groups can be very helpful. Parents of kids with mental health issues, there's developmental groups, there's all kinds of support groups. But also like talking to a neighbor or a friend or reaching out to someone you haven't talked to in a while. Validation is really important. The thing about a support group, like you might think I'm not a talker. I think the best support groups don't require that you speak. I think the best support groups are ones where you go and you're in a room with people before you enter that have some idea of, what you're going through. A very common example is like a cancer survivor group. So before you walk in, like, well, these people have some idea of my journey already. So if I do, number one, I can be validated and feel like I'm not alone. And that is important. It's really important to realize that you are not alone out there. Because I think if you're feeling better about that, you're more inclined to get more help and to try to do more for yourself and then for your kids. So anyway, I just wanted to mention that. And Maria, I want to go to you, if that's okay.
Yeah, I'm going to just kind of keep this brief because we're kind of running out of time. But this is an idea of asset framing. It's basically just defining people or communities or institutions by their positive qualities and starting with that, not neglecting deficits or areas of need, but beginning with that. And it is not a new concept, but the sort of label of asset framing, I think, is novel and useful. And if you're interested in more, this Travian Shorters, I put his website up there, and he did a really powerful podcast with Krista Tippett, and it's an On Being podcast, and that's where I learned about it. So anyways, look into it. It's useful and powerful, simple, but powerful.
Next, thank you. Next slide, Helen. I don't know who's up next. This is me again. Okay, Alex, do you want to talk about the ARC self-plan first? Yeah, let's do that.
So ARC is kind of is a trauma-informed intervention that a lot of schools have adopted, a lot of programs have adopted and are utilizing with students. We are becoming increasingly aware, more society has become increasingly aware that trauma is so hugely impactful on so many of our students' lives, and that as a response, as a effect of that trauma, there are, learning pathways and brain chemistry, all the things that we talked about earlier that are impacted. And so as a result, you kind of have to you have to sort of teach students about these things and about, being able to regulate and manage themselves differently based on that experience. So part of an important part of ARC is about not only, a lot of our presentation has been focused on students and youth and adolescents and their experiences, but as caregivers and parents, and providers, we have to be aware of our own well-being and where we're at. We are not providing our best service or our best parenting or our best caregiving if we are burnt out, if we are, tapped out and have nothing else to bring to the table. So self-care is so hugely important in being better or being able to provide, a quality service or quality or good parenting. Helen dropped for you guys a couple of resources into the chat, and I think she also mentioned that she's going to email them. I have provided, the first thing was there, we talked about self-care, and one of the things about self-care is that as caregivers and parents and providers, we have a hard time maybe carving out that time for ourselves. So there's one item that was provided that is a list of about 1 minute things that you can do to take care of your own self-care. Some of them are just like taking a minute and taking deep breaths. Some of them are writing down a positive affirmation that you kind of reference throughout the day just to kind of reframe yourself and bring yourself back to a healthy place. The other thing that Helen dropped in there is called a self-care plan. So it is one thing to have an idea in your head of, oh, I'm going to do this to take care of myself. As many of us know, it is a whole nother thing to actually put that into practice. And sometimes taking the time to write it out and having a visual reminder of something that you can do when you're feeling like, I don't know where I'm going from here, or I'm just kind of tapped out at this moment, can be that prompt that you need to recognize, I do need to do something right now to sort of manage my own well-being. So it's a self-care plan that kind of goes through, and it's actually, there's a worksheet and a plan. The worksheet kind of works you through how to identify, your triggers and your push buttons, and then how to identify a plan. And then the second part is a plan itself that you can write up real quick and have some place where you can easily reference it, or that it is in your eyesight so it can be a quick reminder.
Great. Thank you, Alex. I want to just add to this that finding something that you enjoy is, I think, really important, because I find for myself, even if I'm only doing it once a week, when I'm having a stressful morning or day or things are bothering me, I can think about that and I know I'm going to have that time to myself. And I know that's a tough thing for parents, especially single parents with a few kids. But I think whatever you can do, like if it's 20 minutes for a cup of coffee when they're all at school and reading the paper, that's old school, sorry, or reading a book or talking with someone, I don't know, but I think it's something that you're really going to look forward to is important. Meditate, we have some things here, find time to do something creative, just find time to laugh, where can you find something to laugh about? I think what's important is we forget that we as the caretakers deserve to feel good. And we should not, I feel like, this is my own value, we should not feel guilty about doing things to take care of ourselves, because we do so much for the kids. We have to take care of ourselves. We have to validate our own value as parents, which is why talking with other adults, getting to support groups, some of us would do well to get some counseling. Not all of us, but if you're wondering about that, then maybe it's a good idea. Okay, again, we're almost out of time. Is there another slide? I kind of forget. All right. Before we finish, I would like to remind people one, that please, before we're done, or as soon as we're done, please fill out the surveys, evaluations of our workshop today. Also, I wanted to ask Stacia and Alexandra and Marie if any one of them has a last word they'd like to throw on. Let me thank you all. This was even better than I imagined you would be. So thank you. But do you have anyone want to do a last word as we go out? Oh, and while we're doing that, anybody have any questions that you haven't asked yet in the chat? We have about 3 minutes. Here's our contact info. You can email Helen to reach me. I forgot to put mine in there, but here's our contact info so you can reach out to anybody with specific things. But Stacia, you got anything? I see your mic's off.
No. I just,
Okay. Okay.
no, not at all.
Okay. Marie or Alexandra?
No, just thank you for this opportunity, Steve, to present for, and thank you for everybody that is participating today. I hope that you have found the information valuable and useful, in whatever capacity that you are serving children around our state. So.
Great, thank you. Marie, is there anything from you or no?
No, I would echo what Alex said. Yeah.
Excellent.
I do see one question in the chat, and I think it's a great one to end on is, do we have a list? Is there a list anywhere of support groups for parents in the state?
I am sure, I'm just going to say, I don't think there's one list. I've seen a couple of coworkers that are here today. I will consult with them. The way I look for support groups is looking for the category of what you're looking for support. Yes, Jennifer put out there parent to parent. Yep. I don't know if they have support groups as I would define a support group for emotional support, but they definitely have groups and they have a lot of good trainings as well. Any of my panelists have any other info about that? Any of that? No, I don't want to cut people off. So a lot of times I would also ask providers that you're already using, the National Alliance of Mentally Ill, NAMI, has peer-run groups, usually for adults, not for kids, but I think if you have kids, you can attend the groups. That would gear toward mental illness, of course, mental health issues, and there's developmental groups. So that's how I would, there isn't one list, I don't think. But if you reach out to me, maybe Helen, could you quickly jot my email in the chat before we sign off? You can email me and then I can help you find more specifically if you're looking for something else. And if there's other groups I can find, then I'll check with my coworkers. I see Ann and Claudia are here, so I'll check with them later today too.
I think also New York Project Health, if you go onto the New York State website, New York Project Health is kind of set up during COVID, in light of COVID. And they have some different resources that you can access. They actually will provide referrals to providers. And they actually have, I'm on the website currently, they have an online wellness group that you can join, but may have some resources around this, particularly because we're kind of in the capital region, so we might be more limited in our knowledge of resources, but they may be able to provide a broader scope of resources around the state.